Welcome, current and future cRNAs. Today we're diving into the pharmacological profile of ketorolac, also known as Toradol, and its role in multimodal analgesic strategies. As certified registered nurse anesthetists, our priority is optimizing post-operative pain control while minimizing opioid-related side effects. In this discussion, we'll examine the latest evidence on ketorolac's analgesic efficacy, hemostatic impact, and its implications for perioperative practice. Ketorolac is a non-steroidal anti-inflammatory drug, or NSAID, that blocks COX-1 and COX-2 enzymes. Simply put, it reduces inflammation and pain by preventing the production of prostaglandins, which trigger pain and swelling. By inhibiting COX-1, ketorolac reduces the formation of thromboxane A2, a compound that plays a key role in platelet aggregation. This is why it's been linked to an increased bleeding risk. However, its COX-2 inhibition is responsible for its strong anti-inflammatory and analgesic effects, making it a highly effective pain reliever. It's important to note that there are currently no NSAIDs that are completely COX-2 selective. Because of its strong COX-2 inhibition, ketorolac provides pain relief comparable to opioids without the risk of respiratory depression. In fact, studies suggest that a 30 mg dose of ketorolac is equivalent to 6 to 12 mg of morphine. Ketorolac is administered as a racemic mixture, with the S enantiomer largely responsible for its pharmacological activity. It's metabolized in the liver and eliminated renally, with a rapid onset, usually within 30 minutes when given intravenously, and a duration of action of about 4 to 6 hours. It's a great option for short-term pain management. Understanding its pharmacodynamics and safety profile allows us to use ketorolac appropriately for optimal patient outcomes. One of the biggest concerns is whether ketorolac increases bleeding risk. A meta-analysis of 27 studies involving over 2,300 patients by Gobble et al. In 2014 found no significant difference in bleeding rates between ketorolac users and the control group. In fact, patients who received Toradol had better pain control and needed fewer opioids. Zooming out to a larger review in 2021 by Bongiovanni and colleagues, this study analyzed over 151,000 surgical patients and found no increased risk of hematomas, surgical site bleeding, or transfusions. In specific surgical populations, similar trends were observed. Breast reconstruction cases showed no difference in hematoma formation between those who received ketorolac and those who didn't. Studies on esophagectomy patients also found no increased risk of hemorrhagic complications. Further evidence includes a retrospective cohort study of 111 patients undergoing oculoplastic surgeries, showing no significant difference in bleeding between those who received ketorolac and those who didn't. Additional studies have shown ketorolac is safe in bariatric surgeries, mastectomy and lumpectomy procedures, and even cranial tumor resections. A 2024 study by Liu and colleagues demonstrated that even in coronary artery bypass graft and valvular surgeries, bleeding risk was minimal. Interestingly, the ketorolac group had fewer complications than the control group. Reviewing the literature from 2019 to 2025 in CINAHL, EBSCO-Host, and Medline, over 160,000 patients were examined, and no significant bleeding risk was found with ketorolac. One of the biggest reasons to use ketorolac is its role in reducing opioid use. Studies have shown that incorporating ketorolac into pain management significantly lowers opioid consumption while providing the same or better pain relief. For example, in breast reduction surgeries, patients who received ketorolac required less fentanyl and oxycodone. Similarly, in bariatric surgery, ketorolac was associated with shorter hospital stays and reduced opioid use, all without increasing bleeding risk. Less opioid use means fewer side effects like nausea, sedation, and respiratory depression, making recovery smoother. Given the opioid crisis, every effort to reduce narcotic dependence is valuable. Additionally, from a workflow perspective, ketorolac enhances efficiency. Patients experience better pain control, require fewer interventions, and often report higher satisfaction. This benefits the PACU as well, leading to quicker wake-up times and less post-operative intervention. Ketorolac is particularly useful for patients who should avoid opioids, such as those with sleep apnea, obesity hypoventilation syndrome, high opioid sensitivity, or elderly patients. However, we must consider contraindications. Ketorolac may not be appropriate for patients with kidney disease, peptic ulcer disease, gastrointestinal bleeding, or bleeding disorders. Its COX-1 inhibition alters mucosal protection, making gastrointestinal bleeding a concern. Additionally, patients sensitive to NSAIDs should not receive ketorolac. Another critical consideration is pregnancy. NSAIDs like ketorolac increase the risk of premature closure of the fetal ductus arteriosus. Therefore, pregnant women in their third trimester should avoid it. Administration at 20 weeks gestation or later has been associated with fetal renal dysfunction, oligohydramnios, and in some cases, neonatal renal impairment. When it comes to dosing, the ideal intravenous dose for an adult under 65 is 30 milligrams, while for those older than 65, it's 15 milligrams. The best time for administration is immediately post-op, after surgical incision closure and hemostasis has been achieved. We recommend ketorolac be administered to an appropriate patient at the end of surgery when hemostasis has been obtained. To summarize, ketorolac is a powerful NSAID with strong pain relief, reduced opioid needs, and a good safety profile when used appropriately. It plays a crucial role in multimodal pain management and helps mitigate the side effects of opioids. Additionally, research indicates that concerns about bleeding risk are not as significant as once believed. Thank you for joining this discussion. Here's to confident administration of ketorolac.